Hello everyone, welcome to our webinar series. First of all, I would like to thank every nursing professionals who were watching this webinar. And today's topic for discussion is all about VATS, the post-procedure care, a keyhole surgery for chest and lung disease. Joining us for the discussion as expert, we have Dr. Manjunath Balaji, who is our senior consultant, robotic and minimally invasive thoracic and lung transplant surgeon from Yashoda Hospitals high-tech unit. I welcome you, Dr. Manjunath ji, and
Thank
we all
you.
are privileged to have you with us for this session.
Thank you very much.
And I also like to welcome our speakers in today's panel, Ms. Salomi, who is our associate professor from Yashoda Lakshmi College of Nursing from Hyderabad, and Ms. Ruchi from Jupiter Hospital, Pune, and Ms. Olivia, a staff nurse from ICCU from Yashoda Hospital's Malakpet unit. And let us see what we have in the rest of the session. We are just going to keep this session very time bound. Yes, over to you, Olivia.
Yes, good afternoon, sir, and good afternoon, everyone who is watching in our webinar. I'm Olivia from Manipur, working as a staff nurse in ACCU department in Yashoda Hospital, Malakpet. Let's go to the topic. We are going to discuss about the video-assisted thoracic surgery. So, in short, it is known as a VATS. It is an advanced, minimally invasive surgical procedure done under general anesthesia. It is used to diagnose and treat abnormalities in the chest, lung, and esophagus. In this topic, sir, we want to know about the details of VATS and what condition can be diagnosed or treated using the VATS.
So, as Olivia told, VATS is minimally invasive surgical procedure to the chest, very akin to laparoscopy. Laparoscopy is done in the abdomen. Whatever is done in the chest, it's called video-assisted thoracoscopic surgery. So, any lung condition, esophageal condition, mediastinal condition, where we have to either diagnose or do a therapeutic intervention, that procedure can be done with a minimally invasive way, which is called as VATS. Now, VATS per se was done first time somewhere in 1999. And since then, many developments have taken place. The most recent, in last over a decade, what we have done is single port VATS. That means we don't even have to put multiple holes. We put a single incision about 3 centimeters, and then we use instruments within that, and we are able to do all the major lung resections within that incision. And even the best part about it is, see, when we do a lobectomy, we have to get the lung out, that part. So the incision is 3 centimeters and lung is like a sponge. So in fact, you can get the specimen out also on the same incision. So at the end of the day, the patient has just one 3 centimeter incision. From what would be a 20 centimeter incision, we have come down to 3 centimeters, and it has excellent results because the kind of pain we notice in the post-operative period is less, the discomfort is less, the recovery is faster. 95% of our patients don't need ICU. The 5% who need ICU are patients who have other comorbidities rather than the lung disease itself. Only they need ICU. Otherwise, after a straightforward lobectomy, there is no need of ICU. And then they get back to work faster, which is very important. See, when a patient comes to us for some surgical intervention, the first thing they would want to know is, when do I get back to my normal life? And that is the beauty of VATS. I have had patients who have gone back within 1 week to their work. And that is the beauty of it. And we have something new in line, which we are doing for the last 2 years, that is called as daycare VATS. That means patient comes in the morning, gets surgery done, and then by evening he's home. And in 2 days, for example, I do surgery on Friday, Saturday, Sunday, they have an off, they take rest, and then Monday they go back to work. This is especially true for IT professionals who have limited leaves. We try to do them on Friday. They take only 1 day leave for a major procedure. Saturday, Sunday, they rest. Monday, they get back to work. And that is something which we have done, which we have improvised with various techniques, not only surgery, the anesthesia care, the nursing care, everything have to be top notch to achieve something like that. And that's where I thank our Yashoda team of critical care, anesthesia, nursing for putting up an excellent team and making it work all the time.
So it was a very interesting fact you provided, that something which even I have learned today as a uniportal VATS. And the clients are all IT professionals sometimes, as you mentioned, as a daycare VATS as well. So here, what are they, like, what kind of conditions they're coming with? Like, do they have a lung problem or some, post exposure to tuberculosis or etc.? Yes, over to you.
So the most common conditions we see in our practice is lung cancers, early lung cancers, because we have a nodule clinic. We have a very efficient way of detecting early lung cancer. So one of those cases are very common. The other cases we see are pleural disease, empyema, which means pus in the chest. There could be pneumothorax, which means air in the chest. Then there is multiloculated pleural effusion, where there is water in multiple places in the chest. We can have post-tubercular destroyed lung, post-tubercular abscess, post-tubercular aspergilloma, bronchiectasis. We have an array of lung conditions which come to us. Now, very simply putting up, any lung condition which is not being treated after optimum medical management will warrant a surgery. So the surgery may be as simple as removing the pleural peel, to a bullectomy, to a lobectomy, to a pneumonectomy. And the most interesting fact is we have such a holistic lung care that there's generally a question: will a patient survive with one lung? Of course they do. And if the both lungs are not working, then we have an option of transplant, which is actually one of the jewel of Yashoda Hospitals.
Yes. As I could see, your amazing achievement, like 3 bilateral lung and 1 heart transplant within 48 hours. So, this is
it was kind of a marathon of one time. I mean, like, it's hard to replicate it again. It was so difficult. 3 transplants, and it was very, very hectic. I mean, I had not slept for a minute, I think, in 2 days. That was the scenario those days.
So, yes, going forward, that was very interesting fact you provided to us. Yes, Salome, this is your turn. And
Good afternoon, everyone gathered here. I am Salome, Associate Professor from Yashoda Lakshmi College of Nursing. It's a great privilege to share the platform with Dr. Manjunath, who is a superhero who is saving lives with his excellent skills. And I thank Shanti ma'am and my principal, Siddhamma ma'am, for giving me this opportunity. Sir, you have given an elaborate explanation regarding the procedure it's done. And now I just ask you, like, is it as effective as the open surgery it's been done? And I also wanted to add a note, like what position they use and how do they select the intercostal space for doing the surgery as well. And also, is robotic surgery is same as this VATS?
Very nice question. So anything which can be done by open surgery now can be done by VATS or robotic. That is absolutely clear. Maybe transplant is the only thing which we are now not able to do for a minimal invasive, but I think in a matter of time that we'll reach a point where we'll do that. Now, coming to your other question, how is it generally done? Most of our procedures are in lateral decubitus position, depending on whether it's on right side or left side. Based on that, we'll place on lateral position. And what we do is we keep it 90-degree lateral, and then we count the ribs from below. Yes. And generally our incision is in the 5th intercostal space, above the 5th rib. But only other thing I will look at is where is the tip of the scapula. If the tip of the scapula is above it, I generally tend to keep it slightly below it, because if we have to extend the incision, you don't want your scapula to come on the way. So we keep 1 finger breadth below the tip of scapula. That will be the incision. That will be a 3 centimeter incision. Very rarely we may have to put another port for the camera. If there are too much adhesions, if the anatomy is not clear, there's a distorted anatomy, if there's bleeding, then what we do is we place an extra port in the 7th or 8th intercostal space so that I have more space to manipulate my instruments.
Sorry to interrupt, sir. Already you spoke about indications like you'll use in bullectomy, lobectomy, and all things.
Yes.
Is it done? This VATS can be done also in children, the pediatric population also, like congenital defects can be treated along while doing this procedure?
Yes. So pediatric age group, I don't do neonates, which is a very, very difficult section. I think the pediatric surgeons do better in that case rather than us. Infants also, we are very selective in doing infants, but more than 1 year, we are very comfortable doing. Our instrumentation is much easier after 1 year. And beyond that, we have no issues. But yes, till infancy, we are generally a little reluctant to do. We would want the pediatric surgeons to take over those cases. After 1 year, we generally take care of all thoracic work. And there was another question about robotic. Yes, robotic is
Yeah.
very similar. In fact, we were the first team in the country to do uniportal robotic lung resection. This was way back in 2022. And then since then, we have done quite a bit in that. Although there is some resistance from my side itself now because of the clashing and a lot of instrumentational issue. But still, we were the first, and we still keep doing it off, on and off single port robotic. And if the single port robot is used, the incision is very similar to uniportal VATS. If you do multi-port, the incision is 8 mm each port. For example, if you put 3 ports, it's 8 mm, or you put 4 ports, it's 8 mm in 4 different locations. But the surgical, this thing will remain same. The pain will remain more or less the same. In fact, with 8 mm Procars, the pain is significantly lesser.
Thank you, sir.
So that is how it is a wonderful MIS and ultra minimal precision targeted technique surgery, I think. Yes. And I would like to, witness the surgery as well. Yes. Yeah.
I would be happy to have our staff anytime.
Yes, yes. And I was just going through about this condition, and I think Ruchi would like to speak about this. Yes, Ruchi, over to you.
Hello, my name is Ruchi and I'm from the Jupiter Hospital, Pune.
Hello,
And
Ruchi.
hello, sir. And I would appreciate, sir. Sir is explained very well and about the indications and the VAT advancement surgeries. That is a minimally invasive surgeries
Yes.
To the conventional.
comparatively, it is a very I can say the ultra minimal surgery, high precision surgeries. So I would
Yes.
like to know from the sir, like it is a what is the hyperhidrosis? I want to know about that more about this.
Hyperhidrosis is a condition, it's an idiopathic condition where patients have excessive sweating in the palms and soles. That is called as palmar hyperhidrosis. Some patients have axillary sweating, some patients will have craniofacial sweating. So it can be axillary, palmoplantar, or craniofacial. Now, in this condition, what happens is they have, for example, normally we all sweat.
Yeah.
When there is a change in the ambient temperature of the room, there is a sweat. And we all sweat, and after some time, the sweat stops. But for patients with hyperhidrosis, the trigger is persistent. Once they sweat, they'll keep sweating, and the sweating will not come down easily. So in such a scenario, what happens is there is a sympathetic overactivity. So what we do is we go identify the sympathetic trunk, clip it so that the activity of that sympathetic trunk is hindered. That's how you stop the sweating from then and there. This is the simplest procedure. Now, I was talking about daycare procedures. Sympathectomy is one of those procedures where we do daycare, and it gives, they are done without anesthesia. Not with only IV anesthesia and not intubation. We do a non-intubated daycare VATS sympathectomy for these patients. So this condition is just done under a LMA, laryngeal mask airway, not even an intubation. So the beauty of this is patient comes home, comes to the hospital and goes back by evening, and he can go back to work the next day also. So that is the kind of improvisation we have made in terms of sympathectomy.
And patient will have the normal sweating activity after this post-procedure?
Generally, we are happy if they have some sweating, but most of them come to us saying that we have very dry hands now.
Okay.
Yeah. In a way, it's the success of the surgery, but also we are still leaving back something for the patient to worry about. What we do is we ask them to apply more moisturizers and keep it dry. And we ask them which one was better, whether the wet hands were better or the dry ones. They would any day prefer a drier hands.
So yes, so that was very interesting, thing. So here my doubt arises again when you said that you have done this thoracoscopic sympathectomy. So
Yes.
when you do the clipping interventions for palmar hyperhidrosis, so craniofacial and this what is it, plantar thing also is subsided, I think. Yes.
So it depends on where we're cutting it. It's
Yeah.
the level. If the level is at the second rib, then it takes care of craniofacial. If it's at the level of third rib, it takes care of axillary. If it's below that, then it takes care of palmoplantar.
Yes. Yes, so now we are just going to talk about the nursing care and coordinations. Yes, Olivia.
Yes,
Yeah.
sir. We are going to discuss about the pre-procedure nursing care and coordination. We should ensure to send the metasurgical profile, including the coagulation profile, X-ray to the echo chest, CT chest as per the order, and PAC prepare high-risk consent, get cardiac referral and any other clearances if the patient has comorbidities present, etc. Reserve blood if this required. Part preparation of chest should be done. Keep the patient on NPM and administer antibiotics and shift to OT on time. Effective handovers to pre-op nurses.
Yeah.
So,
So
apart from these are all, bedside nurses protocol and parameters which they are supposed to monitor. Anything else, you wish to tell in this forum? Since, yeah.
Sorry to bother. My query, is there excess blood loss or the blood loss is very minimal because it's a keyhole surgery? Is it
I'll answer.
required? Yeah.
Yes, I'll answer both
Yes,
the
sir.
questions one by one.
Yes.
So the first one is there any investigations required more than this? You will need a pulmonary function test if you are planning to remove any part of the lung. That is because you have to ascertain that whether the patient will have a normal functioning lung or is it a capable lung to manage his respiratory activities after the diseased lung is removed. For example, if I remove lobectomy, that means I'm taking 1/3 of the lung. If that much amount of lung is removed, what will happen to the patient? Will he be able to breathe normally or he will need any oxygen assistance? That is something we should know. For
Yes.
that, the simplest of test is PFT, pulmonary function test. So invariably, we do pulmonary function test before any lung resection. Okay. Now, lung surgeries, although we are doing keyhole, are dealing with something major. The vessels are directly coming from the heart. We may not transfuse in most of the patients. For example, we may transfuse in less than 10% of patients, but we arrange and reserve the blood for 100% of patients, because when it bleeds, you can't be running for cross match.
Yes.
You should be a step ahead. You
Yes.
won't get that much time to do cross match and do all that at that time. It's rather safer and more methodical to arrange and keep the blood in the blood bank ready. If and when we need it, we will need it very quickly.
Yes.
So,
Yes,
sir,
Ruchi, just
sir,
written,
is that
Ruchi,
true is that true that anticoagulant should be stopped before the surgery as
yes.
the risk factor is there?
Yes. So if there are, for example, if it's aspirin alone, 75 mg, I wouldn't mind. I wouldn't stop it. But if it's a dual anticoagulant, dual antiplatelet, then we would definitely stop clopidogrel for 7 days at least. Clexane, I would want at least 24 hours of hiatus. Although 12 hours is what they recommend, but 24 hours hiatus is a better one, because when these patients bleed, they bleed a lot.
Yes.
They will drain out the heart. So you imagine everything is coming out through that. So one has to be more careful about anticoagulants and antiplatelets when you're planning for surgery. If there is something, we should bridge them properly on low molecular weight heparin and then do that.
So every nursing professional should keep these parameters in mind, as Sir has rightly pointed out. Yes, and as you said, the duration and length of stay, I think you have already provided. What I would wish to understand, what is the duration of this surgery, like the VATS with the
So the
normal
duration of surgery totally depends on what procedure it is.
Yes.
And what is the complexity of that procedure. For example, decortication can take 1 hour or it can take 6 hours, based on how bad the lung is, how bad the adhesions are.
Yes.
For a straightforward lobectomy, it can be 1 hour. For lung cancer surgery, where we operate on lung cancer, it's only 1 hour. The operative time is 1 hour. But the kind of cases we get here are much worse, because we give chemotherapy, immunotherapy, and then operate. Or we have patients who have had TB earlier and then who come with lung cancer now. Those patients are very difficult to handle. They will take longer time. and the surgical duration will be somewhere around 3 to 4 hours minimum.
Yes. Going forward, this is our main topic, post-operative and post-procedure care. Yes, over to you, Salome.
Yes, nurses, it's very important for post-operative management. So assessment of frequent monitoring and vital signs especially, and noting the saturation and blood pressure levels of the patient is crucial, and IV fluids and careful monitoring of intake and output of both the, where the chest drainage is connected, that also has to be monitored, and medications are as prescribed. So it is included in IPSG goals, as we know already. We have to follow the IPSG goals, and then encourage spirometry and nebulization to the patient. So early ambulation is better, as we know already. Any surgical cases also, we go for early ambulation. So head elevation must be done unless the patient is ambulated. So adequate pain management is one of the important aspects that has to be noted, and chest tube insertion site has to be noted. And also sterile dressings has to be administered, kept to the patient, and then see that the area is dry. These are all the nurse's responsibility. Adding up to this, what more the patient has to be advised regarding either weight lifting or doing strenuous exercise, not immediate post-op, like more. So and also when can be this chest drainage tubes like removed, like how many days they will be inside?
So the first thing I tell any patient after a surgery, before the surgery, is you can have your dinner with your family. Okay, which is a very important thing we should, as nurses also, as a team, convey to the patient in the preoperative phase, that don't worry. Generally, the have dinner with their family. Although the dinner may not be a full course meal, but whatever little, they can still have it at their room. That is the kind of assurity we give to our patients, because we have seen that often happen more often. Then the next thing, I think you covered most of it, how to manage everything. The first day, our concern will be two important things in the drain: whether there is blood in the drain, whether there is air leak, which are two important things. The surgeon should be informed at the earliest, even if it's 100 ml, because that first 100 ml may be just a warning bleed and there may be more blood collected inside. The second thing is leak, whether there is any air leak. Now we use the advanced drainage systems, which will tell us the degree of leak also. They can say how much leak is there in the machine. So that way it helps us a lot. But these are two things which the nursing team has to see, apart from looking at the patient's monitor and patient's chart. And these two things, I would be very happy if the nurses tell me before I ask them. That means that nurse knows what I'm looking for and what is important for the patient. That is something very important, and that is something we should look for. And as I said, we allow them only on the same day. And the patient goes home and he says, I had dinner with my family. That's quite reassuring for the patient and for the family, that a job has been done at a very good level.
Yes.
And
think
regarding removal of the drains, if the drain is serous, that means there's no blood. If there's no air leak and less than 100 ml is the standard, we remove the drain.
Yeah. And I think this is the modern designs which, than the having this water seal conventional method.
No, we no more use the water seal.
Yes.
Yeah.
So that is in, that is, and it prevents a lot of, nursing related handling errors as well.
Agreed. Easier to handle.
Yes. And what kind of diet a patient can take? It is all the time the high protein or anything?
Generally, we ask them to take a soft diet on the day of surgery, after the surgery. Once the next day onwards, I literally ask them to eat whatever they feel like.
Yeah.
Of course, I mean, I don't want him to have spicy biryanis, which is not something I would order anyone. But then I would want him to have a good balanced diet comprising of more proteins. Because of course, if you have a good high protein meal, the healing is better. So I generally ask them to have a good high protein meal and then as early as possible resume their normal activities.
I think we have come to the end of the discussion, and I again ask here, Ruchi or Olivia or Salome, do you have any other concerns to be just clarified with? And as I think I will like to ask this question, when patient can resume his outdoor activities or work, if at all the patient is outdoor worker or professional? Yes.
1 week, I think. 1 week should be a good time. Yeah. But we have seen that our patients are a little more skeptical than us.
Yes, yes.
The guys who are doing office jobs, they go by 1 week. Some patients who are, for example, if someone is a real estate business, he would rather wait for a little longer than going. Although we advise them, but still they will take it a little slower. They feel बहुत बड़ा surgery हो गया, मैं कैसे हिलूं? All those things will be there in their mind.
That's the mindset, yes. And any medications or any take-home medications which a patient should be continued, you know?
Generally, we advise them analgesics for a few days.
Yeah.
Or if it's an infective case, we advise antibiotics also. But if it's a non-infective case, we advise some analgesics, some some antacids and stuff like that. Nothing major.
Yeah.
We try to keep them less burdened from medications because they're generally not helpful after the surgery. Once the surgery is done well, generally we don't need anything else.
So yes, we have learned.
Like
Yes,
so
Salome.
the time healing of that, so like keyhole, whatever is open, like how many days it take? Like 15 days?
Yes, yes. And an average of 2 weeks.
Yeah,
2
yeah.
weeks. Okay.
Yeah.
Yeah. Good question. Yeah. And
Yeah.
so yes. Lot of
Thank you, sir.
belief and the facts we have cleared here, and this half-an-hour session is not enough to understand about VATS and its advancement. So, do the ability of these the expertise surgeon, another Dr. Manjunath ji. Yes, I urge all the viewers to just refer www.yashodahospitals.com for more health updates, academics, and also watch a patient testimonials and doctors' health talk for evidence. Based learning. I think, yes, we end the session. I thank Dr. Manjunath Balaji and Salome Ruchi and Olivia. Thanks for your participation. I request you all to share the link for others to just learn more about VATS. Yes, we end the session. Thank you.
Thank you very much. Thank you for having me.
Thank you, sir.
Thank you. Thank